Hello, I'm Matt Galloway, and this is the Current Podcast.
Basically, I went to my doctor saying I got a sore throat. He goes, it's a virus, get out of my office. Okay. But then in June or July, I went to him and I go, hey, look, I'm coughing up blood when I'm playing hockey.
Turned out Paul Lonergan had tongue cancer. Doctors removed the tumour and treated him with chemotherapy and radiation. And then, like all cancer survivors, Paul wondered, was he really cancer-free or would the disease come back? Here's how Paul's story is different. He was able to get some answers to those questions through a new clinical trial here in Toronto. Scientists at the Princess Margaret Cancer Centre are using an emerging blood test technology. It's called a liquid biopsy to look for small traces of cancer in a patient's bloodstream, which in Paul's case, they found. Because doctors found these cancer traces early, Paul got more treatment and he is now cancer-free.
I'm so lucky to be here and the support from my friends and family.
Dr. Lillian is a senior scientist at the University Health Network's Princess Margaret Cancer Centre and a scientific lead at the Peter Gilligan Centre for Early Cancer Detection Research. She is the lead researcher of what is known as the Sherlock clinical trial. Dr. Sue, good morning.
Good morning.
Can you just start by explaining what the liquid biopsy is?
Yeah, thank you very much for having me on the show. Liquid biopsy is essentially exactly what you just said earlier, which is we're trying to take a blood sample to look for tiny quantities of DNA that is shed by the tumor cells into the bloodstream to understand whether perhaps a cancer is still present despite patients having gone through definitive curative treatment for their cancer. Biopsy is a term where we use to say we get a sample of the tumor, and conventionally a biopsy is to put a needle into an organ, for example, lung or liver, to get a piece of that tumor, which is very invasive. And liquid biopsy is trying to do this through a body fluid, such as blood or urine, to be less invasive.
The study is called Sherlock, and that hints that there's still some mystery there. What are you hoping to learn over the next 5 years?
Thank you for understanding what we're trying to say with the Sherlock acronym. It is definitely a Sherlock endeavor. We're trying to really understand whether we can use this kind of novel technology to detect. And this technology is not new. We've been, and others in the world have been trying to fine-tune it and develop it into a more sensitive assay in the last decade. And Sherlock is a study, as you said. It's a platform study which allows us to include all kinds of cancers, including solid cancers and liquid cancers. And we're trying to build the data, the evidence to understand whether these tests using liquid biopsy can help to predict that the cancer would come back or would not come back based on the detection of the DNA that I mentioned earlier.
So we heard a bit of Paul's story there. He was able to participate in this trial. What made him a prime candidate?
First of all, obviously, he's informed, he's interested, and he has that detectable molecular residual cancer in the blood. Now, he subsequently went on an additional study which allows us to test a new immunotherapy which eradicated his cancer. These are very, very new studies, so we need to build the evidence. So it is not a standard of care. We cannot now go out after today and say start using it without actually understanding in the longer term whether these tests do pan out to be reliable and accurate. And obviously the addition of new treatment or additional treatment after patients have MRD detected or molecular residual disease detected also is a clinical trial.
How common is it for patients to have residual cancer? In Paul's case, he had surgery, had chemo, radiation, then the liquid biopsy still found tumor DNA in his bloodstream. How common is that?
That is exactly what we're trying to understand and collect the information for during the Sherlock study. It all depends a lot on the kind of cancer, because some cancers don't actually shed this kind of DNA into the bloodstream. And also depends on the stage. If the cancer is very early in the stage, there's a much lower incidence of this shedding into the blood versus a higher stage cancer that already is perhaps more advanced in the diagnosis.
And so people might think, if through this liquid biopsy a residual cancer is found, the residual tumor DNA, does that mean for certain that the cancer is going to come back? Because that finding in itself might worry people, like, oh, I got cancer again, like it's going to come back.
Understood. And that's why this kind of clinical research clinical trial is so important. We understand from previous published studies that the chances are very high if we can detect molecular residual disease, but it is not 100%. There are some cases where the cancer will spontaneously disappear. And obviously that would be great. Perhaps the body's own immune system is trying to fight and get rid of that residual cancer. But without clinical trials like Sherlock, we just don't have the ability to say that for certain across different cancer, what's the predictability of this test being accurate to predict the cancer will come back. And we need to study it to know it.
Given that finding tumor DNA then doesn't always mean the cancer will necessarily come back, there are some doctors questioning the ethics of worrying patients potentially unnecessarily by giving them this information. What do you say to that concern?
Well, first of all, I think patients like Paul come into the clinical trials as an informed participant. They understand the reason and they sign the consent form to agree to participate. I would argue that it is not ethical not to study it. I think it is important we collect the data so that it is accurate, so that we can inform our future patients what is the right thing to do to learn more about what MRD does mean to their care.
What are the chances that this has a false positive or a false negative? We know that with a lot of kinds of tests that happens. An incorrect finding, if you will.
I will tell you after we finish the study, because that is exactly what we're trying to learn after enrolling 7,000 patients into the Sherlock study. We just started. This study is starting currently at the Princess Margaret. In time, we will extend to other cities and towns in Ontario to include the 7,000 participants. But we need data to learn to tell you the false positive and false negative rates.
Could this technology eventually be used for early cancer detection? In other words, right now, you have to have biopsies and scans to determine confidently whether someone has cancer. Could this be like a game changer in that respect?
Yeah, I think this is what the research is about. The Sherlock study is looking for people already diagnosed with cancer, having gone through curative treatment, and we're trying to see if the cancer is remaining or will recurrent. But there obviously the usage of DNA in looking at people without cancer to see if we can detect early signs of the cancer, so-called multi-cancer early detection or MCET test. It's a different kind of scenario. And what we learned from the molecular residual disease, I am certain will inform us about what we will do in the MCET situation in terms of early cancer detection. But all this requires investment and time and energy in terms of understanding about molecular residual cancer and circulating tumor DNA.
What's next in the study?
We're actively enrolling. As I said, it's currently open only at Princess Margaret, but we expect to extend it to other places within Ontario and to really understand more. And we're contributing knowledge to other groups in the world doing this kind of study. I think this is very exciting.
Dr. Su, you know very well that Princess Margaret is a leader in research when it comes to cancer in the world. And there's lots of trials and tests going on. How much promise do you see here with liquid biopsies?
I wouldn't be talking to you if I don't think this is promising. And I think we want, obviously, the excitement, but we don't want this to be a hype. We want this to be a realistic understanding. This is a clinical trial. It's a platform study allowing us to learn over time what is the right thing to do and what is actually not going to be appropriate to do. And we need the support to understand how to collect the evidence to make this a reality. Dr.
Su, it's been very good to hear from you this morning. Thank you.
Thank you very much.
Dr. Lillian Su is the lead researcher of the Sherlock clinical trial into liquid biopsy. She is a senior scientist at the Princess Margaret Cancer Centre here in Toronto and a scientific lead at the Peter Gilgan Centre for Early Cancer Detection Research.
This has been The Current Podcast. You can hear our show Monday to Friday on CBC Radio 1 at 8:30 a.m. in all time zones. You can also listen online at cbc.ca/thecurrent or on the CBC Listen app, or wherever you get your podcasts. My name is Matt Galloway. Thanks for listening.